My name is Jesse Gutnick. I'm one of the bariatric surgeons in Cleveland Clinic. We've got a great seminar set up for you today. I'm joined today by Jamie Sarver. She's got a dual role. She's both one of the administrators for our department, but is also a weight loss surgery patient herself. So she's going to talk about things from both perspectives. And of course, Karen Schulz, who's the head administrator for the whole department and is one of our obesity medicine specialists. Just to give you a small lineup of what we're expecting to do today, we're going to start off by hearing Jamie's story. I'm going to talk about some of the science behind weight loss surgery, both in terms of how it works and the safety profile. Karen Schulz is going to speak about what to expect in our program, and then we'll open it up for a Q&A. Please feel free to submit questions to the Q&A throughout the procedure. We'll kind of collate them and curate them at the end. All right, so with that, I'm going to hand things off to Jamie, and we can take it from there.
Hi, everybody. Thank you so much for joining us today on a Friday afternoon. I know you're probably all trying to get home and relax for the weekend. So my name is Jamie Sarver. I'm one of the nurses in the Bariatric and Metabolic Institute. And you can see here, this is my picture of me back in September of 2019. I'm right there in the middle. That was me at pretty much my highest weight of my entire life at 253 pounds. And so you can go ahead and share the next slide. I like to use this picture or this series of pictures just because it really shows my progress over my entire almost 4-year journey of having bariatric surgery, and just my progress throughout the period of time that I've been working on this, or ever since surgery. But this is my surgeon, Dr. John Rodriguez. He's currently over in Abu Dhabi. But I've tried to catch him every time he's in town, just so I can get a picture, just to show the stages of my progress. Next slide. So a little bit of information about me. Prior to bariatric surgery, I, at the time, was 34 years old. My highest weight, like I said, was 253 pounds. I really didn't have any significant comorbid conditions. I just had polycystic ovarian syndrome and some infertility. But I actually knew that there was kind of like a storm that was coming to me if I didn't do something about my weight. My family history, I had, a long history of obesity on my mom's side. As well as my dad's. There was several people that had struggled with obesity. But on my mother's side, I had diabetes that was onset later in life. So my grandma, my great-grandma, they all, developed type 2 diabetes as they got older. And so to me, that was a bigger concern for me, as well as fatty liver disease and some of those other types of things. I had known about bariatric surgery for several years prior to even starting working in this department. But to me, it was always just something that was like, it's out there. I don't know how to even get to this point. I don't know if my insurance covers it. I don't even know where I would begin. And I was fortunate to start working in this department where I was able to kind of work with the surgeons and work with the team and have a better understanding and knowledge of just obesity and why certain things were working for me and why they weren't. And so during the time that I had started working here, I did try diet and lifestyle interventions. I was doing that prior to even working at the Bariatric and Metabolic Institute, but they really just were ineffective in maintaining the weight loss. I was able to lose weight, 10, 15, 20 pounds I would lose, and then, right away it would kind of come back on, or I would just notice that I would start kind of plateauing and I wasn't, making any other changes. And so it really wasn't helpful. And I was starting to kind of just like lose steam on that, where I was getting really just, tired of myself, of like, I'm trying everything that I can do and nothing is working. And so that's when I really started considering having the gastric bypass. I wound up having the gastric bypass in December of 2019. My day before surgery weight was 233 pounds. Currently, I hover between 120 and 125, and I've been maintaining that weight for about a year now. I think I got down to like 160, and I was there for a little while, and then I wound up doing some more to kind of push my weight loss efforts a little bit further, and that's how I got down to my current weight. My time in surgery was about an hour and 20 minutes. That was from the time they actually wheeled me into the operating room and then wheeled me out of the operating room. My total time in the hospital was about a day and a half, but we typically tell patients, it's not a race to go home. We want to make sure that you're doing well. So every patient is going to be a little bit different. Sometimes it depends on your surgery, on what surgery you have. Sometimes it just, depends on you and how you're tolerating fluids and if you're passing gas, all of that fun stuff immediately post-op. But for me, it was about a day and a half. I had about 3 days where I was like, oh my goodness, I just had surgery. My abdomen kind of was like tender. I was taking, heavier pain medication like oxycodone, that kind of thing, where I was, needing to take that more frequently. But after about that 3 days, I was just taking Tylenol as I needed it. And really, I wasn't needing it very often. I was moving and walking pretty well within that 3 days. I went home at a day and a half post-op, and I immediately, like the place that I was staying up in my sister's attic. And so they had a nice room up there, but I had to walk up 4 flights of stairs just to be able to get to my bedroom. And so I was able to do that even at day 1.5 post-op. I was still able to kind of get up and get downstairs and move around and all that kind of stuff. Within 4 weeks, I was back to work. Typically, we do have a 4-week FMLA process where you need to stay off of work for about 4 weeks, but that varies for each patient and depending on what type of work you do. Just for me, my work kind of was a little bit more able to have me be off, make me take that time to kind of take care of myself, form better habits, that kind of thing. But depending on your job and what you're doing, if you're, working at a desk or something like that, we do talk to patients about maybe just being off for 2 weeks, that kind of thing. But that's going to be a discussion for you and each patient and their surgeon. So next slide. So I like to show this slide. This is actually my weight progress over a course of 5 years of working with our department. I've been in this institute for about 6 years now. So I like to show, like, this is me, my weight history with this department, and how those changes have occurred over the years. So prior to surgery, you're going to see that graph portion that's on the left-hand side. You're going to see I kind of was stuck around that 250 pounds. I did take medications during that time to try to work on weight loss prior to bariatric surgery. And you can see I lost some weight. I lost about 25, 30-ish pounds. But then those meds kind of started not working as well or not being effective. At that time, the phentermine laws, there's a medication called phentermine. Those laws were a little bit different, where you wound up being only able to be on them for 3 months, and then you had to go on a 6-month hiatus from the medication. So I lost a good amount of weight, 30 pounds. Then by law, I had to stop taking the meds. And you can see I just started kind of gaining my weight back. A little bit before surgery, you can see that's where I was kind of at my highest weight, that 253 pounds. And that's when I made that ultimate decision. I'm doing surgery. I'm done trying to fight this tooth and nail just for a little bit of progress. I'm ready to make the leap and do surgery. And you can see right there my surgery date of December. I was 233 pounds, and then there's a very, very big drop within that 6-month post-op. I wound up losing the majority of my weight. So I'm talking between 60 and 70 pounds. And I got down to about 160 during that time. My weight loss after 6 months kind of started slowing down, and you can see I had that nice, straight kind of like plateau for a little while. And then myself, I just kind of knew that in my employee health plan, I still was above the normal, what is a normal BMI. And so I still knew I needed to do a little bit more work, and I started focusing on that. And you can see I was able to continue to lose a little bit more weight at the just after 2-year post-op mark. Next slide. So these are some of the immediate milestones. Within that first year, there's a lot of really big and significant changes that kind of happen in your life. And so I try to make sure I tell patients or patients that are interested in surgery, I try to really keep good track of, what was that like for me in that immediate post-op stage within that first year. And so in the first 2 to 4 weeks after surgery, you're pretty much on a liquid diet. You have this brand new, just a brand new little pouch or a baby pouch that really cannot tolerate very much food or a lot of contents in it. Essentially, it's about the size of an egg, but there's also some swelling. So you're taking sips of water. You're really not able to eat any food. You're pretty much relying for the most part on protein shakes as your main source of nutrition during this time. And then you're also working to reach at least one of those protein or water goals. You are given, when you meet with our dietitians, each patient meets with a dietitian, you're given a specific amount of protein that your body requirement is. There's a calculation for that. And so mine was about 65 grams of protein daily. And so I was able to get that, 64 ounces and 65 grams of protein. I was trying to hit at least one of those two goals on a daily basis within that first 4 weeks. And then I also knew it was important during that 4 weeks to get up, get moving. My surgical pain wasn't it wasn't really significant. So I was definitely doing walking and making sure that I was getting exercise. And I was also taking that time for myself to really build some really good habits to, make sure that I was doing things the way that I should be doing. So making sure that I'm starting to take my vitamins, getting in a daily habit of that. And really just kind of taking time for myself during that 4 weeks to focus on what do I need to start doing to make sure that, I'm doing what I'm supposed to be doing. At 1 to 3 months post-op, this is where I knew I was hitting my, water and protein goals daily. I was already back to work at this point. And so I had developed those good habits to make sure I'm drinking my fluids, know when I'm thirsty, know when I'm, recognize those signs to make sure that I'm actually getting my water goals in, even when I'm at work and I'm a nurse and I know I got to take care of other people and not think about myself. And so those types of things were things that I was making sure to recognize at that 1 to 3 month post-op. During this time, your weight loss is also starting to be very noticeable to not just you. I mean, literally, there was days where I would go every single day and I'd, be, getting ready for work and I'd be like, oh my gosh, I'm already smaller than I was yesterday, or a shirt that I just had on the day before is all of a sudden too big or something like that, where it's you're really noticing your rapid weight loss. And other people are noticing it too. I also noticed right at 1 month post-op, immediately when I went into work, I noticed just my activity level had changed. I was able to, walk upstairs and not be winded or as winded. I was able to, even working the floor, after working 8-hour days, I would come home and my feet would be so sore prior to surgery. And even at 1 month post-op, I remember oh my gosh, I'm not coming home with my feet dying. I was able to start wearing high-heeled shoes, which I would have never even considered doing prior to that to work. And so I really noticed those kind of changes right away at that 1 to 3 month post-op. At 3 to 6 months post-op, this is where I say food is finally your friend again. A lot of that internal swelling that you have just after surgery, it kind of subsides. And so that's when you have a little bit more ability to eat some variety of food, as opposed to just kind of focusing on making sure you're getting your protein and your actual nutrients. And so you're not having any kind of malnutrition type issues. I'm finally able to actually eat and enjoy food again, or start enjoying food again. But I'm also still really losing weight at a really good pace. And so that makes you feel good. Every time you turn around or get on the scale, you're like, oh my gosh, I dropped another 10 pounds, or oh my gosh, these pants again, they're I have to go to a different size, that kind of thing, where you're really just noticing that. And again, that activity level significantly improved. One of the things that I remember during this stage, we actually have a wood burning fireplace, and it was during the summer that I wound up being that 6-month post-op mark. And my husband had to work, and so we had to get firewood to prepare for the winter. And I remember having to go with my dad and get all this firewood that we wound up getting, and it was like literally 4 truckloads that my father and I loaded and unloaded in my backyard. I would have never been able to do that by myself, but I mean, I couldn't believe just with my activity level, and I wasn't like in any kind of pain or anything like that afterwards. So to me, at that point, I was like, wow, this is something that I never would have been able to do, prior to bariatric surgery. At 6 to 12 months, this is where you can really see that major change. So you've had a significant amount of weight loss. It does start kind of slowing down. You're starting to incorporate more foods or varieties of foods, like the raw fruits and vegetables and things like that that you kind of got to stay away from initially. I was hitting my protein and water goals daily. If I was not getting in enough protein or water, it was because I just was not taking care of myself, essentially, as opposed to not being able to get those fluids in. At this time, I also started really recognizing those minimal cravings for things. Again, right at that 6-month post-op mark was the summer, early summer, June. And that's my son's birthday month. And I remember that being one of the first times I really recognized the mental change that it kind of gave me. But that was like the first year in my son's entire life that we wound up throwing away like half of a birthday cake, because the cake just sat on our table. I didn't have any kind of triggers like thinking like, oh my gosh, there's cake in there, I should go and have some. So it wasn't getting eaten. And so for me, that's when I really recognized like, wow, I'm like not even thinking about food, or not even thinking about like these like sugar cravings, or that I need to go in the kitchen and have a piece of cake or have cake after dinner. Those types of things that were constantly running in the back of my mind prior to surgery. At this time, we're also really comfortable with those anatomical changes. And when I talk about that, sometimes after surgery, you have like certain things that you can eat, you can't eat, even going to the bathroom, those types of things. You kind of get used to like, okay, I know I did something wrong. Maybe I ate too much food, or maybe ate too fast, or I, had food, while I was drinking something, or, ate a little bit after I had a bunch of fluids, so then I didn't really eat as much as I should. Those types of things where you kind of what you're doing as far as like your actual anatomy. You're kind of used to that, those changes at that point. I also recognized during this time a lot of changes in my self-confidence. I had lost a significant amount of weight. I felt good about myself. I finally felt like what I felt like I needed to feel. For me, for surgery, I did it because I knew I needed to do this for a health reason, but also I didn't feel that great about myself. I was sick of looking in the trying to get ready every morning and being like, oh my gosh, well, I guess this is the best I'm going to be able to get, feeling like crap in all of my clothes, and not feeling good about myself. And so by this point, the changes in my confidence level had completely turned around. I felt like, oh my gosh, like I'm going to make sure that I fit in these clothes really nice. I'm going to make sure I look nice too. Those types of things. And then I also noticed at that time changes in intimacy and like my relationship with my husband. So my husband really, he was okay with the way I was before. He had no need for me to have surgery. He knew it was something that I wanted, but it wasn't something that he did not mind my weight. And so after surgery, though, I recognized a change in him where, we would be out and we would see people, and this was during COVID. And so we would see people that we hadn't seen in like a while, and he'd be like, look at Jamie, doesn't she look great? Look at how much weight she's lost, So for him, even that kind of change, he recognized, in me that I felt better about myself. He recognized all of those types of things. And so it kind of helped to change our relationship. And he really actually started working on making his own changes and changing his diet and his lifestyle as well. And he was able to even lose some weight from that. During this time, I also like to talk about some of those non-measurable goals that like I didn't recognize that I was even missing out on. until after I had surgery. So putting on a sock while standing up, being able to even reach my toes and paint my nails without, really being winded. Some of those types of things are things like you don't even think about until after you have surgery and after you lost weight, and all of a sudden you're like, oh my goodness, like I am, sitting so far away from the steering wheel, or I'm able to kind of get out of bed a lot easier, or my balance has improved. And, those are things that you don't think about until you actually have experienced them. And you're like, wow, I would not have been able to do this if I hadn't have had surgery or hadn't have lost this much weight. Next slide. So now that I'm, about 4 years post-op, I like to talk about like, how did I maintain this investment in myself? And how am I maintaining my weight loss? I work in this department, like I said, and so I hear people that, they come back and they're like, well, I had surgery and I gained all my weight back, or I gained a lot more weight back. And so I like to just share, like, these are the things that I'm doing to make sure that I've continued to, you know, keep that investment in myself. So even still to this day, I am mindful of how much sugar is in everything that I put in my mouth. So even if I want a piece of candy, I check how many pieces of candy can I have before I have this amount of sugar that goes into my body. It can make me feel sick, or it can make me, have this thing. It's called dumping syndrome. And so it makes you just kind of feel like jittery. It makes your heart race. Sometimes it can make you feel a little bit sweaty, but it just makes you not feel very good. And so I'm very careful of how much sugar I'm putting in my body at one time, just because I don't want to feel like, crap, essentially. I don't want to feel ill. And so I'm very careful about that. And that even comes down to like simple carbohydrates. So if you're eating a bunch of crackers or maybe eating mashed potatoes, there's certain things that you can eat and you can't eat. And, eating so much of it can make you feel okay, or it can make you feel not well. And so I'm mindful of those. I'm also mindful of how much protein and water I'm getting on a regular basis. And so usually I try to, when we're at the grocery store, I'm always trying to make sure that I'm purchasing higher protein types of foods. So looking at how much protein is in, a serving of my yogurt that I'm going to have. I want to make sure that all of those types of things, because I can only have so much of it, it has the highest amount of protein. So it's helping me to get my protein intake in for the day. And then also even my water intake, I'm making sure that I'm, each day, like I know how much, I have at work. I have a 12-ounce cup. I try to have 2 of those in the morning. And then I try to have 2 cups at least in the afternoon. And then I know, well, I've gotten 48 ounces of water in for at least while I'm at work. And I can kind of focus on making sure that I'm getting the rest of that water intake in, during the evening when I'm at home. And then I'm not so nervous that I didn't get enough fluids in for the day. I also am regularly daily either having a protein shake or a protein bar, something like that, just so that I can make sure that I hit those protein goals. Also exercise. You may have already seen providers that tell you, diet and exercise is super important. And even in our department, we talk about exercise on a regular basis. And I will be the first person to admit I talk about it, or I did talk about it. And the providers told me, make sure you're exercising, but I rode that wave of, oh my gosh, I had gastric bypass and I am losing weight so fast. I don't need to exercise. I'm active already. So I have a big yard. We did a lot of yard work during the summer. I definitely was, an active, I am an active person. But I started noticing during that plateau, or times where I wasn't losing as much weight as I thought I should be, that there was probably something more that I could do. And I have a couple pictures that I'm going to show you, where I'm going to it'll prove to you why exercise is actually really important, especially that weight resistance training. Cardio is definitely important, but the weight resistance training, I'm walking proof that it is a thing that every patient should be working on from the time that they're approved for exercise by their surgeon. They should start doing it. And then also continuing a daily vitamin regimen. I was taking vitamins beforehand, and so that wasn't really a change for me. I keep my vitamins right by my home office. I have them in a little cup on my desk, and then even in my work office. I have them again in a little cup on my desk, and it's just a daily reminder. Make sure you take your vitamin. And so those types of things are really important. Another thing that I try to stress to every single patient is continuing with post-op appointments. I actually still, to this day, 4 years post-op, see my providers for my annual post-op visit, get lab work done, all of that kind of stuff. And I work with the providers that actually see the patients, the obesity medicine team. So we're the team that actually sees those patients post-operatively. For the rest of your life, we want to see you. And so I see the patients that do come in and they maybe had surgery 4 or 5 years ago and they've gained their weight back. And how come, what was the reason that you had this gap in following up? And they a lot of times they're like, well, I gained my weight back and I didn't want to come in, or I was too embarrassed, or things like that. And a lot of times we try to explain to them, it's great that you're coming back and getting on track, but it's also really important to maintain those post-ops because, there could be diet or lifestyle changes that we could catch maybe when you're only 10 pounds heavier, or maybe you're just plateauing and maybe there's something that we could catch earlier than waiting until you're, 30, 40 pounds at a higher weight, or maybe you've gained all your weight back. So keeping up with those post-op visits is a way for you to maintain that investment that you had made in yourself. Whenever you make that investment in yourself, it's a way for you to continue to maintain that every single year, making sure that your vitamin and mineral levels are okay, all of those types of things. So I try to just make sure I share, like, those are the tips that have helped me to stay successful with maintaining my weight loss. And so my next slide is proof that exercise is important. Okay, so this is my favorite pictures of myself. So you can see summer of 2020, this was the 6 months post-op. I was still on that, like, oh my God, I've lost so much weight, I feel great. But you can see I also was not toned. I was about 165 to 170. I really was like kind of stuck there for a while. And I really kind of had to take a minute and evaluate, well, what am I not doing that, maybe I should make some changes or something like that. So that fall, I started exercising with my sister. I don't have a gym membership. I have a rowing machine downstairs in my basement, and I have a free weight system. And so I started just doing free weights and rowing and doing that exercise. And you can see by the summer of 2021, I actually have like abs and I have biceps. And that was the thing that was so important for me, is that for the first time in any of the time that I had been working on trying to lose weight, I actually noticed that change. And I, actually exercising on a daily basis or on a weekly basis, I was able to see, like, oh my gosh, like my arm muscles feel stronger. Or, oh my gosh, my ab muscles, like I can see my ab muscles. This is amazing. Those types of things, where prior to surgery, I could exercise for 6 months straight and I would not even see any kind of change. After surgery, I was able to see that change like immediately. And so that really helps to build my confidence. It really helped to make me just keep me on track and keep me motivated to continue to be doing the things that I'm supposed to be doing, like that, getting the protein in, getting my water in. Really it helps to kind of motivate me to continue to work on myself. So I really like sharing this screen or this slide. You can see my weight, it went down a little bit, but that level of tone and just my body fat deposition really had changed. And another thing I like to comment on when you're looking at this picture, I had no, and I still have not had any kind of loose skin surgery, no plastic surgery whatsoever. This is literally just from diet and exercise changes after surgery. I think that might be it for my slides. If you want to advance the next slide, Dr. Gutnick. So yeah, that's it. That's my story. But thanks for joining us, and I'm happy to answer any questions at the end.
Well, thank you. Well, I'm going to get into some of the science behind how these surgeries work. So basically, your weight is somewhat determined, or mostly determined, by a system in your body that works like a thermostat. Just like in your house, your thermostat, if it's getting colder outside and your heat's turned on, when it senses your temperature going down, it kind of kicks in and brings your temperature back up. Likewise, in the summertime, when it's getting hotter, kicks in and brings the temperature in your house back down. And that is just sort of that's just sort of how your body works to maintain your health. But that can be sort of derailed once you've unfortunately been suffering from obesity, it gets to a higher set point, just like if you set your thermostat for 80 degrees inside your house. And so when you're dieting, your body senses that as a sort of not a good thing, as a signal to have all those things kick in to raise your weight back up. Whereas with weight loss surgery, it reprograms how your body manages food, and we call it resetting that set point. Some of the mechanisms behind this, the most important one is what's called our basal energy expenditure. That's just how many calories we burn when we're not doing anything in particular, like I'm just sitting here talking to you. I'm not exercising or doing any heavy work, just sitting here talking. So when you diet, your body turns down your metabolism to maintain that, your current weight. Whereas after surgery, your basal energy expenditure actually increases. Similarly, when you're dieting, all the hunger signals that are hormonal and neurologic are going up. After bariatric surgery, they're turned down. Your sensation of fullness goes down when you're dieting and comes up when you have had surgery. Your stress hormones go up when you're dieting, and they decrease after bariatric surgery. And then a bunch of gut hormones that are involved in the above mentioned things go in the opposite directions as well. The most common operations performed are gastric bypass and sleeve gastrectomy. Some less common ones are the duodenal switch and the SADI operation, and then occasionally some revisional surgery. Mostly corrective, if there's an issue with a prior operation, but also depending on the person's situation, for failure of weight loss or for weight regain or persistent obesity. I'm going to go through just the pictures of the most common ones because these are the ones that some of the medical studies that I'm going to bring up were measured on. So the first one is gastric bypass. You can see it's on the right-hand side of your screen. It's a stomach bypass. Gastric is the medical word for stomach. Then on the left-hand side is the sleeve gastrectomy, and this one is an operation that's only done the stomach, and the stomach is made much more narrow, and the part that expands when you eat a meal is removed. That's called your fundus. The reason we go through these ones is because there's been a lot of randomized controlled trials and very large studies showing how these help your health. This was one of the most important ones. The most recent publication was in 2017, looking at a 5-year follow-up of what's called a randomized controlled trial. Basically, they flipped a coin if you got best medical therapy, the sleeve gastrectomy or the gastric bypass. And they measured, all these patients were diabetic. They measured how the diabetes was doing over time along with weight loss. So first look at the weight loss. This chart on the left-hand side, you can see that's time 0. On the right-hand side, that it's at the end of 60 months or 5 years. The people that had the best medical treatment for their diabetes are in the yellow line, and you can see they did lose several BMI points over the course of that time. The patients that are in the sleeve gastrectomy are in the sort of teal, and gastric bypass in the orange. And you can see there's a very large decrease in the BMI over time that is persistent over time. Similarly, and the real importance of this study was all the patients were diabetic. So they were comparing the diabetic control, but the best medical treatments versus surgery for diabetes. So again, in the yellow line, you can see these patients were treated very aggressively medically, and they had a 2% drop in their hemoglobin A1C, which is actually a huge drop for a medical treatment. But you can see that gradually went up over that course of the next several years, close to where they started on average. On the flip side, if you look at the gastric bypass and the sleeve, they had a really rapid decrease in their A1C, up to about 3% less on average, with a slight increase over time, just to about 2.5%. So that was a persistent improvement in that A1C, which is a really important marker of how your diabetes is doing. So similar to the diabetes, weight loss surgery helps treat what we call metabolic syndrome. So all of the other health issues that go along with obesity, and they're sort of laid out, most of them are laid out here in this figure on the left-hand side. And really, hopefully we can prevent them. Hopefully you have the treatment prior to getting any of these health issues, but In any case, almost all of them will stabilize, and most of them will often reverse, either partially or fully. And with that, I want to talk about the safety of weight loss surgery. When I look at the safety of any medical intervention, whether it's surgery, a medication, anything else, there's two important things to look at. The first is to look at the risks of the treatment, and then to look at the benefits of the treatment over time. When it comes to something like a medication, you have to look at the risks over time as well as the benefits over time. With surgery, it's really the risk of surgery is front loaded because it's a single event, and then that health benefit is stretched out over many years. And the studies we're going to go through are over several years, but we even have some studies that are nearing the 20-year mark that are a little bit more general than the ones I'm presenting here. There was really a revolution in the early 2000s for the safety of bariatric surgery, which was caused by a combination of two things. The first was, and the most important was, applying the laparoscopic technique to these operations instead of the old-fashioned open technique. So really starting in the early 2000s, it's really started in the 90s, but people really started adopting it in the 2000s. And you can see that for every 1,000 operation in 2002, the risk of in-hospital death was 4 out of 1,000. And by 2009, that had decreased to 0.6 per 1,000. Today, that rate has gone down even more, and the risk of mortality across the United States is essentially well under 1 in 1,000, and probably even lower than that at this point. So that has to do with the safety of the actual operation. If you want to look at it another way, and in sort of a comparative way, our group compared in diabetic patients the risk of having some of these other operations compared to gastric bypass. We chose diabetic patients because if you're diabetic, you're more likely to have complications after surgery than if you don't have diabetes. And so we wanted a group of people that were at higher risk so that we could really highlight the differences. So for example, you get a heart bypass operation, that's a CABG, CABG, you have a 46% risk of complications after surgery. Knee replacement with diabetes, you have a 16% risk, and these are operations that people get every day. Colon operation, 12%, and then even things that are thought of as very benign, gallbladder surgery or hysterectomy, right around in the 3% range, and then gastric bypass is right at the same level as like a hysterectomy. It's about 3.4% risk of any complication. This isn't just major complications, but this is even a small one. Now, similarly, we looked at how people do over time after weight loss surgery, again in type 2 diabetes, but focusing on cardiovascular outcomes over time. And this graph shows the rate of cardiovascular events after the time when people either were enrolled or had surgery. And you can see the non-surgical control patients had a much higher, steeper angle of cardiovascular complications like heart failure, coronary artery disease, arrhythmias, stroke, kidney disease, or high blood pressure. And that's a much slower rate after metabolic surgery. So, in summary, it's not just about diabetes or heart issues, but it's really all those things in the metabolic syndrome that are greatly benefited over time. And we even know from large registry studies from Sweden that over time you have a significantly longer life, and it's through treating these other health things. So it treats sleep apnea, diabetes, improves the safety of childbearing, improves the quality of life, especially joint pain, so you can be more active. There's even a decreased risk of certain cancers that are related to obesity, and it treats fatty liver and many more things. So with that, I'm going to turn things over to Karen Schulz to talk a little bit about our program and what distinguishes it.
Okay. I don't see any questions in the chat yet, but I just wanted to mention if anybody has any questions as we're moving forward, feel free to just put them right into the chat box on your screen. So I want to just thank everyone for attending our webinar today. I'm going to wrap it up with just some information about the program and how to take next steps. So, and in addition to being an administrator, also advanced practice nurse. So really has been a great experience working with patients and getting them to their goal. So I hope I'll be a good resource for you. So Cleveland Clinic tries to deliver care as close to home as possible, and this is in bariatrics as well. In fact, we deliver a lot of our care now in your home. We do a lot of extensive virtual visits, especially for people who are from out of town, maybe have a busy working schedule. We'd like to see you, if possible, at least one time in person. It's a great time to pick up our educational booklet, meet your provider, but we also understand that life is very busy. We try to be out in the community as much as possible. We have regional access. 3 centers of excellence near you. We operate at main campus, centrally West Side, Fairview, and Avon. We're just opening an outpatient center in Westlake on Monday. And then on the east, Hillcrest Hospital, Mentor is going to be up and running soon, and Twinsburg is our outpatient center. We also see patients at Richard E. Jacobs. So just lots of places. We try to be in convenient locations for our patients. Next slide. And of course, we know you live in Cleveland, so you have lots of great choices for healthcare, but we appreciate you thinking of the Cleveland Clinic. We are, you can see, very highly rated, as you can see, for U.S. News and World Report, best hospitals in Ohio, and main campus #2 nationally, which is where the bariatric surgery program is based, even though we operate at all those different sites. Next slide. So starting the program might seem a little overwhelming, so we do provide lots of assistance for you. Once you take the online seminar, which is the next step, we will check your insurance, and then each candidate for surgery has a patient navigator. So that person's going to help you, first of all, find out if you have coverage for bariatric surgery. If you do have coverage, what are the requirements of your insurance company? They'll communicate with you about that, and then a scheduler will reach out to you to make those first appointments if you'd like to move forward. Next slide. All right, after you we check benefits and you receive your first welcome letter from your navigator, the next step is to make appointments with our team. We have a pretty extensive team here at the Cleveland Clinic to help you get through the pathway. We have 9 registered dietitians. We have 3 obesity medicine physicians and 7 advanced practice nurses who specialize in obesity medicine. We have 7 psychologists and 11 bariatric surgeons, all specially trained in this field. In addition, at the clinic, we have every possible consultant that you could need: sleep medicine, cardiology, endocrinology, but we can also work with your physician. So I know a lot of you already have specialists that work with you, including mental health care providers, primary care physicians. So we can work with them. Any testing you've had recently can all be used, as long as it's recent, towards your evaluation for bariatric surgery. Next slide. All right, so that is the completion of the program. I see there are a few questions in the chat, so I'm going to ask Dr. Gutnick and Jamie to come back on, and then we'll get to the questions. But the next steps you can see there on this screen, I mentioned that there is an online seminar. So that is sort of the next step. It's different information than what we presented today. It's more detailed as to like what it's actually like to be a patient in our program. It's optional. It's about 30 minutes. You can watch the seminar if you'd like, or you can just go on to clevelandclinicweightloss.com and register for the program. There's about 15 questions that really help us to organize the best number and sequence of appointments that you would need. And then 1 to 3 days after you complete that questionnaire, we're reaching out to find out, first of all, to tell you if you have benefits for bariatric surgery and what is required, and then ask you if you would like an appointment. So just because you're taking that registration and seminar doesn't obligate you at all. Some people just want to find out, if I would consider bariatric surgery, would it be covered? That's kind of the first question. If you do have coverage, then you receive a welcome email and we'll get you started. All right, I see a few questions coming into the chat here. So I'll direct the first one to you, Dr. Gutnick.
Okay.
Is the gastric bypass preferable to the sleeve method? If so, why?
Well, I think that's a really important question, but I'm going to completely scramble it because I think it's actually getting at it wrong. And apologies to the person for saying that they're getting at it wrong. There's several different options for weight loss operations. The most commonly performed one is gastric bypass. I'd consider that the gold standard because it's the one that's been performed the most over time. But that does not necessarily mean it's the best one for an individual person. It's the one that's in the middle in terms of the amount of weight loss that can reasonably be expected based on large studies. Typically somewhere, if you look at the middle 50% of people, how much they lose, somewhere around 25 to 30% of their weight. But depending on what your weight loss goal is, that might be more than you want or not as much as you would want for your personal weight loss goals. Also, depending on your prior abdominal surgical history or your health issues, we may want to go with one or another. So that's really the most important part of the evaluation you have with your surgeon on that first visit, is going through your medical history, your surgical history, what gastrointestinal symptoms you have, if any, and what your weight loss goal is, and using all that information to choose the best operation for you in particular.
Okay, thanks, Dr. Gutnick. And you don't have to choose the surgery that you want before you enter the program. The surgeons are really great at working with their patients to help them decide which operation is the best one for you.
Yeah, and often people will come in with one in mind, and that's okay. Oftentimes, they'll have had a family member or a friend or someone from their work who had a particular operation, had a good result, and that kind of inspired or prompted somebody to look into it for themselves. So it's totally okay to come in with something in mind. We're not going to try to necessarily, disagree with you, as it were, but more just sort of educate people about what all the options are and how they would work with them in particular.
Okay. The next question I'll direct to Jamie. What is the typical time frame from starting the program to reaching a surgery date?
So that's definitely a complex question. So each patient, it really depends on your insurance coverage. So some patients, when we call and check your insurance benefits, we're going to find out what does your specific insurance require if you do have coverage for bariatric surgery. Some insurance companies want patients to go through, it's called a medically supervised weight loss. And so some insurances don't have that requirement where you'd have to meet with a dietitian. And some insurances may have 3 months, some have 6 months, or some have like a specific number of visits that you just have to reach. And so it's kind of important for you as a patient to just kind of know that going into the program, that's going to kind of be based on what your insurance requirement is and how long it's going to be. So if it's 3 months, 3 visits, that means about 3 months. During that time, each of our providers, you would meet with each of our providers. So we kind of try to do all of the things that you need to do to meet our program requirements while you're also meeting those insurance requirements. So at the end of that time, ideally, we would like you to be pretty much squared away and ready to go for surgery. So it really kind of follows that kind of pattern. So the time that you register, if your insurance says that you have 6 consecutive months or something like that, during that time, you would do your workup, and you really want to make sure you as a patient do all of those things that you're supposed to be doing. So if your insurance says that you have to be seen 6 times every single month, you want to make sure that you come in 6 times every single month, or not necessarily come in, but have a visit, just so that you can stay on track with what you're supposed to do, so that by that 6th visit, you've completed all of the, workup that we need from you. And then we can submit to your insurance right then and there saying, hey, this person has completed what you require as an insurance company, and this person has completed the steps that we need to make sure that they're going to be safe for surgery. Well, can they have surgery? And we get that approval from your insurance company so that you can move forward with surgery.
All right. Thanks, Jamie.
Mhm.
I'll take the next one. This is a question about remote employees. I guess it's a Cleveland Clinic employee, but really we can answer it for anyone that lives a distance from the Cleveland Clinic. So what's really great about the virtual visits is people that don't live near a Cleveland Clinic can still receive access to care in our program, because as I mentioned before, almost all the appointments can be done virtually. Usually there's a pre-op visit with your surgeon, and of course the surgery. Need to come with us, stay with us for at least a day. If you are a Cleveland Clinic employee in particular, there's a few extra requirements, such as you have to be an employee for 2 years, and there's a few other things. So the HR website is great with the details as far as being a Cleveland Clinic employee. The other thing is, if you want to get your testing, if we need any medical testing done, those orders can be sent to whatever location is convenient for you, even if it's not a Cleveland Clinic facility. So we can work with outside physicians, outside labs, whatever it is you need. That's, it's not a problem. We're used to doing that. People come to us from really all over the country. Okay, this next one has to be for you, Dr. Gutnick.
Okay.
If the sac created by the bypass surgery is much smaller than your stomach, how is it that people gain their weight back?
So, so I think when they're talking about the sac, they're talking about that very small pouch that's made at the top of the stomach. And so, just to give everybody a reference, we typically shoot for that to be several ounces in size, or the size of a large egg. And so, I think to kind of give a counterexample of how people don't gain their weight back is you can look at Jamie's excellent presentation about her own journey. And she's eating a normal amount of food, or slightly much less than she was previously. And the food that she is choosing is nutritious food. And so when we do food surveys of people that tend to have weight regain, they tend to be eating still a smaller amount of food than they were before, but eating high density, calorie density food, number one, and very, very low texture food, number two. So that even though that stomach is quite small, if it's a low texture food, it moves out of it very quickly. And so that's sort of one important component. So those are things that are to some degree changeable or preventable. The second one is that, just like any other therapy, all operations have a variable response depending on the person's everything else. So 2 people could have the exact same operation, have the exact same habits, unless they're identical twins. And even identical twins won't probably be exactly the same, but even unless they're identical twins, they're not going to have the same exact response to it. And that's just like any other therapy. That's, if you have high blood pressure, you may respond well to a medicine called a diuretic, like hydrochlorothiazide. Someone else might take that and not get a big response. Now, everybody's going to have some response with surgery because it's such a powerful therapy, but there's going to be a difference in the weight loss that each individual person achieves based on their age, gender, hormonal balance, genetic background, and that kind of thing. Some people are just more strong responders than others. So I guess the main question would be, how do you maximize so there's 2 things. Number one, me as a surgeon, how do we make sure that you have the best possible operation? And that's making sure it's done technically perfectly. the same way for each patient, based on what we know are the important factors for, number one, optimizing weight loss, and number two, preventing weight gain from a technical perspective. From you as a patient, the most important things that you can do are really learning from the registered dietitians. They're definitely not just a hoop to jump through for your insurance company. Their insurance company may have you jump through that hoop, but they're really there to help you set you up for success over the long term. The other thing is having some kind of moderate.
Did we just lose his audio?
I think we lost his audio. Dr. Gutnick, I think your audio went out.
Yeah,
Loss over time.
there he comes. Your audio faded out for a minute
Oh,
there.
I'm so sorry. Well, anyway, I don't know where I faded out, but
Just like the last two sentences, I
Oh,
think.
yeah. So, a moderate amount of exercise that includes a combination of strength and a little bit of cardio, just like Jamie does, has been shown to be really critical for maintaining weight loss, both in patients that are doing non-surgical weight loss, so other things, medications, only diet, and plus exercise, and also in patients that have undergone weight loss surgery. That's a blanket effect that no matter how you lost your weight, it's important in the maintenance phase. And that's for a lot of different scientific reasons, but basically it keeps that basic basal metabolic rate up that I was talking about. It keeps that up over time. The power of bariatric surgery it persists over time, but it's not to the same strength over time. So that helps maintain the weight loss.
Okay, I'll take the next one. Someone's asking if you have a mental illness, can you still get the surgery done? And the answer is yes. A lot of our patients have different challenges, both medically, emotionally. We look at mental illness just like any other health issue that someone may encounter. You don't have to be perfectly healthy in every way. We just want you to have each of these items in the best control possible. So that's why one of the reasons everyone sees psychology. If you're currently seeing a mental health care provider, we may have that person reach out to us before you even have your first appointment. So that's why the initial intake questionnaire really helps us. It'll ask some questions about different aspects of your life so we can set up your appointments in the best order that's possible. But absolutely, mental illness of any kind is not necessarily a contraindication, as long as you're in a good situation and things are stable. Okay, the next one I will direct to Jamie. What if I've already tried to lose weight by taking prescription medication supervised by a doctor? Are those efforts basically counting toward the insurance requirement for bariatric surgery?
Okay, good question. Yes, some of them can. So our obesity medicine team here, we're the ones that do that medical workup. It just kind of depends on, I know our physicians in our department, they do also, when you come in for those medication appointments, they will ask, diet and lifestyle type questions and talk to you about those types of changes that you've also made. And that's kind of like that important factor that maybe your insurance kind of needs to see. So it just depends on how that provider note is documented. If they count, but in general, most of the time, those visits can count as a placeholder. That's what I like to call it, as a placeholder. That obesity medicine provider, it can count as one of those nutrition visits that your insurance might require. However, that is not that visit that you need to have with one of our dietitians, so that we can make sure that you do know what changes you need to make permanently after surgery in terms of your diet and what to expect with your eating habits after surgery.
I think if it's okay, Karen, I'll quickly add something else, if that's all right. Almost 100% of the patients I see now, not 100%, but almost 100%, have tried some types of weight loss medication previously, whether that was Adipex or one of the newer ones that are, really in the media. So the caveat is that a lot of them are new, and we don't know long-term how they interact with surgery. but as far as we can tell anecdotally, they seem to be additive. So, for example, if you tried Ozempic and it did not work that much for you and you didn't get a huge effect from it, you still lose weight with weight loss surgery. Similarly, I see many patients that started on Ozempic, got some good weight loss. Let's say they got 30 pounds, 40 pounds even, but they still suffer from morbid obesity because where they started from, that 30 or 40 pounds is not enough to get them where they want to be. And they also lose weight with weight loss surgery. So we're still, because they're new, we're still learning a lot about how they interact. But so far, they seem to be to some degree independent or additive. And not, if I took this, then surgery definitely won't work. It really seems to be the opposite. And sometimes they work together quite well. And I've had some really good success with them working together as well. Sort of accentuating the weight loss that they would have had from weight loss surgery, or the surgery accentuates the weight loss if they started with the medications.
Okay. All right. Someone's asking about Medicare and Medicaid. And yes, they both do cover weight loss surgery. Depending on which type of Medicaid you have, there might be some different requirements. And we'll let you know that once you enter the program. But all of the government plans, fortunately, do have coverage for weight loss surgery. And that's because they know it works, and it will save them money as you get healthier, and they don't have to pay for all of the health issues that go along with the disease of obesity. Along with that question, someone was asking now, how do we know as you go forward about all of your medications and being able to get off of them? And so that is something we work, very carefully with you and your primary care physician. Some of those medications, especially the diabetes medications, can be stopped immediately after surgery because of some of the metabolic issues that Dr. Gutnick spoke about that cure diabetes in some patients, not all, just because they had surgery even before the weight loss. So every patient is different, every medication is different, but that careful monitoring by your primary care physician, you're seeing us on a regular basis for those first 6 months. So we're all kind of watching to see how your medications are and which ones can be discontinued at different times. Okay. Are you still with us, Dr. Gutnick? I think we lost your video now. Did he go away?
It's showing he's still on. I'm not sure what happened.
We cannot hear or see you. We'll give him a minute. Let's see if there's anything else here. We're getting to the end of the questions. What happens if you have gastroparesis? That's a pretty advanced question there. Gastroparesis is actually is often favorably impacted by bariatric surgery. It is not a reason to not have surgery. Oftentimes people come to us with gastroparesis and have bariatric surgery, most commonly the gastric bypass. So it does increase gastric emptying for some of those patients suffering with that disease. And gastroparesis, for those of you who aren't aware, is just the stomach more slowly emptying than a healthy stomach. Okay. Let's see. Looks like we're not going to get Dr. Gutnick back. We can't see him right now. But long-term contraindications for surgery, I'll do my best with that one. Someone's asking, and that's a really good question. This is something we do for life, as Jamie knows, and maybe you can help me with this one too. There are some things that you need to be careful about with these operations. Those patients taking anti-inflammatory medications may be directed to the surgery that preserves the muscle at the bottom of your stomach, which is the sleeve gastrectomy. If you're dependent on those medications, you may be directed to a gastric bypass. And it's really because of the chance of gastric irritation or ulcer after surgery. Patients with severe gastroesophageal reflux disease or heartburn may be directed to one surgery or another. That's something you definitely would want your surgeon to know about. He may do some testing and that might impact which surgery you have. You don't want to smoke after, especially gastric bypass surgery, because that can increase your risk of ulcer. And very rarely do we see anything major such as bowel obstruction, but that can happen in rare situations after any type of abdominal surgery. Vitamin deficiencies, we also see those, but with the bariatric vitamin, those are pretty rare. And I think the word is contraindications, like long-term, yeah. Can you think of anything else, Jamie?
No, I mean, even for me, simple things, growing up, I always took like ibuprofen as opposed to Tylenol. That was just like the drug of choice when you were having ailments, things like that. So it's definitely something that you have to kind of take in consideration. So anytime even I have a headache or, I hurt my back or my feet hurt or, something like that where I'm having some kind of pain, I had to get kind of in that habit of, choosing the Tylenol over the ibuprofen just because the ibuprofen is an NSAID. And it can kind of give me issues. So, patients that maybe have migraines that take ibuprofen or take some of those types of medications, you definitely want to make sure that you speak with your doctor prior, or maybe you have back pain, like just consistent back pain that you're taking those types of things on a regular basis. You're going to want to talk to your provider that's prescribing you those NSAIDs prior to surgery, because you're going to want to have a plan in place afterwards. Say you do get migraines on a regular basis and you're taking something like an ibuprofen to help relieve that, you're not going to be able to take that consistently because you're going to be at risk for giving yourself an ulcer. So just making sure that you take those steps before surgery so that you know what to do after surgery, or you've already had that conversation with your provider when you're, hurt your back and you can't take any ibuprofen, and now they're wondering, why are you suddenly asking me for, tramadol or something that, is a different type of medication. Or maybe is a different type of, controlled drug that you normally wouldn't be trying to get. But that's a serious conversation now that you would have to have, just because of some of those drug issues that, we've seen over the last few years. So just make sure that you have those conversations, and even any kind of medications that you're on, like patients that we see post-operatively that have like really high blood pressure. We really try to make sure that we encourage them, make sure you have that 2-week post-op visit, even with your primary care physician or whoever's managing these medications, because with that weight loss, those types of meds can be affected. And so you're going to want to just kind of any meds, go over, have a once over with your physician, your primary care physician, or whoever's prescribing those, just so that you can make sure that as you progress with your weight loss, your blood pressure is going to get better, and you maybe don't need as strong of a blood pressure medication as you were taking. Those types of things are really important to just keep in mind prior to surgery.
All right, thanks, Jamie. So I did get a message from Dr. Gutnick that he had something urgent he had to step out for. So I'm going to take one more question and then we'll wrap it up here. Somebody had asked about, they heard you can't have a colonoscopy after bariatric surgery. So that is not true. The colon is not impacted by bariatric surgery, just the small intestine and the stomach. The thing that might be different is the prep. Sometimes your gastroenterologist will not have you drink quite as much of the liquid. So it is important to discuss with your doctor before a colonoscopy for a different bowel prep. But a lot of our patients do the standard bowel prep. Okay, so the next steps are up on the screen. We did say clevelandclinicweightloss.com to watch the seminar or register. You can also just go to the Cleveland Clinic website and type in bariatric surgery. There's lots of ways to get to that seminar, but there's a big button that says take the first step. And I think you'll find that the online seminar is informational. That will direct us to checking your benefits. I know at least one person on the line said that she hadn't heard anything back, so I do have your name and I will check. You also want to be in touch with your email, because in the rare case that you do not have coverage, they'll usually send you a detailed email on what to do next if you didn't have coverage. So that might be the case for the one person that hasn't heard back. Okay.
A couple of things I was going to add on that. So just some follow-up on the emails. Make sure that within just a couple of days, you're checking even your spam and your junk mail. Sometimes it's like a bulk generic Cleveland Clinic email that comes through from that initial, like, thank you for registering, here's your information kind of thing. So pay attention to your junk and spam mail. Sometimes it can get filtered straight to that. And then also when it comes to scheduling, it's really important. Our scheduling team will call you from a 216 number to try to set up those first appointments. And I'm personally guilty of it myself. If your number's not in my phone, I tend to not answer it. And so if you don't have your voicemail box open, or maybe you don't have a voicemail box, or it's full or something like that, and they can't leave you a message, we won't be setting up those appointments, just because there are 4 visits and those are for new patients. So you don't automatically get those visits set up until you speak to one of our schedulers and we know that you're ready to actually move forward with the program. So just kind of make sure within that first week of registering, you're kind of checking your emails, answering those kind of calls, your voicemail box is open, all of that kind of stuff, so we can leave you a message, just so we can stay in touch and know that you're ready to actively pursue going through our program.
Okay, and with that, I'd like to thank everyone on the line today for joining us for this bariatric surgery seminar. We wish you all the best of luck in your weight loss journey, and have a wonderful weekend.
Bye, everybody. Thank you so much.
Bye.